Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
On this episode, Dr. Elizabeth Squirrell joined us to talk about Crohn's disease. Dr. Squirrell is a staff gastroenterologist at Queen's University. In this two-part series, we first talk about the diagnosis of Crohn's disease and the different patterns of its presentation. In part two, we talk about the changing landscape of medical therapy for Crohn's disease and how Dr. Squirrell approaches the treatment of Crohn's. Make sure to check out the links below for all the papers that are discussed in both part 1 and part 2 of this series.
Dr. Squirrell, thank you so much for joining us today on the Cold Steel Podcast. It's an absolute pleasure and an honor to have you on the show. We're lucky enough to work with you as colleagues here at Queen's. And so thanks for joining us today to talk about medical management of Crohn's disease and a lot of the things that I probably don't know that I don't know about the diagnosis and management of Crohn's disease. Can you tell us a little bit about where you grew up and where you did your training?
Well, thank you for having me on the podcast. It's a pleasure to be here. I grew up actually in Alberta. I grew up in Edmonton, a little town just outside of Edmonton, which is no longer a little town. I grew up in Beaumont. When I grew up there, we had a grocery store called Big Way, which is now a dollar store. I hear that town has exploded since then. I did my undergraduate in Edmonton, and then I went on to do medical school in Calgary. From there, I moved all around Canada. So I knew when I was in Calgary that I wanted to move for at least one part of my training, because I think that that's it's a rare opportunity that you get in medicine where it is almost more socially accepted to move around a little bit more. And I think that it really does broaden your horizons a lot. And it really allows you, the Canadian healthcare system is not one system. And so being able to see different experiences, different provinces was really something that was important to me. So I did my internal medicine residency in Newfoundland. We drove from Calgary to Newfoundland to move. And then my GI fellowship brought me to Kingston. And then I decided that that wasn't broad enough. And I had to go to Vancouver for a year for inflammatory bowel disease. But then I have gotten a little bit tired of moving. So now I'm settled back in Kingston. Throughout that time, I did the special focus on inflammatory bowel disease with the group in Vancouver, and also did a master's in epidemiology through Memorial. So started that in my internal medicine residency. And now that's done and I'm settled.
That's a wonderful journey. And I feel like a sense of kinship with you because I've done very similar west to east kind of journey. And I couldn't agree with you more about going around different places to train. Like, it's amazing how accepted some practices are in some place, and then you go somewhere else and they totally challenge everything that you thought you knew about a topic or a way of treating something or dealing with a certain patient issue. So I think it gives you a certain breadth and to an expansion to the way that you approach things. So Elizabeth, why did you decide what was it about inflammatory bowel disease that attracted you in the first place?
There's a lot to the chronic disease management of inflammatory bowel disease that I appreciate. I think one of the things that drew me to GI in general was that there's such a variety in the presentations you get. You get very acute disease that you can treat. You can cauterize an ulcer and never see the patient again. And that has a very rewarding and very nice role. But the chronicity with inflammatory bowel disease was something that I found very intriguing. I like the complexity of it and the puzzle of it sometimes, and following along with those patients and seeing the patients when they're quite sick and seeing them when things have worked, or kind of just walking with them through when things don't work. I think that IBD is historically a disease of young people, though that's changing. And these young people are navigating everything through each step of life, but with a chronic disease that's hard for them to talk about because it's not something that you talk to your friends about. It's not something that your family members talked to you about. And so it's something that I think they feel they can be in a very vulnerable position. And that being able to kind of walk with them and help them through that, I find very rewarding. I think we got really lucky in the timing that we are working in inflammatory bowel disease. The changes in IBD care in the last 10 to 15 years have given a lot more hope for people. I go down rabbit holes of medical research, and usually when making a presentation, and I get really into like the history of how different treatments evolved. And if you go back to like the 1930s, they tried lobotomies for ulcerative colitis. And with the premise that they felt better afterward, I guess, and published it and said, look, these 5 people we did lobotomies on and they weren't complaining of their bowel disease afterward, but also they still had bowel disease. There wasn't steroids at that time. I think the first treatment was really the 1950s that we had available. And then we've just hit this revolutionary period of treatment for it. And I'm really hopeful that we'll even have better treatments as time goes on. I tell my patients that I'm hopeful that in their lifetime we'll have a cure for it. And I'm quite hopeful that we will as we advance. But I think we've got this like lucky time period of it, right? We're not stuck without medication, telling people that it's all in their head.
Totally. Wow. That's one way to get rid of a problem, is to just take out the part of your brain that senses any issues with it. And I completely agree with you. Like, as a surgeon, it's actually so much rarer now that we get referred patients with, refractory colitis or Crohn's disease. And I'm fine with that. If I don't have to operate another Crohn's patient in my life, I'd be totally okay with that. So this is a huge topic, and there's no way, obviously, we could capture all the nuances of IBD care or Crohn's disease management or diagnosis or anything like that. But I wanted to use your expertise to help our audience to kind of develop a bit of an approach to perhaps some of the new things that are happening in Crohn's disease. And so, starting right from the top, can you talk to us a little bit about the diagnosis of Crohn's disease? I actually think that, and I have had discussions about this, it's not necessarily a very straightforward thing to how you diagnose Crohn's disease. What goes into making the diagnosis of someone with Crohn's disease? Do you need a biopsy? Is it based on imaging? How do you approach that, the diagnosis of a patient that's sent to you with query Crohn's disease?
It is truly a clinical diagnosis with a lot of supporting factors that you bring into it. With Crohn's disease, a little bit more than ulcerative colitis, you may have asymptomatic patients or you may have minimally symptomatic patients. The classic symptoms that you think of when you think of inflammatory bowel disease or you think of Crohn's disease specifically, you would think of more pain, whereas with colitis or ulcerative colitis, you may have more kind of bloody diarrhea. With Crohn's disease, you may have more non-bloody diarrhea with abdominal pain as a predominant feature. I find a lot of patients, we perhaps don't ask enough about bloating associated with the pain, in part because in most GI clinics, you're going to have a lot of people with bloating as a common feature without any concerns for inflammatory bowel disease. And then a lot of the symptoms are truly non-specific symptoms. So fatigue, you may have patients coming in with anemia or at times rectal bleeding, especially if the disease is in a colonic distribution, then you're going to have more of the typical colitic symptoms. So you can have all the classic symptoms of ulcerative colitis with frequent bloody diarrhea, with tenesmus, and it can still be Crohn's disease. And then you can have patients who have, a small burden of inflammatory disease in the small bowel who don't have many symptoms. A lot of the symptoms do come from more progressive disease when it's in the small bowel, so more obstructive type symptoms. And in the more symptomatic patients, I find that it's often with rectal disease that you have a lot more obvious symptoms. And I think those are the ones that we catch a little bit earlier, because the rectal disease is hard to ignore because it causes a huge burden on quality of life. So then you have those general symptoms that you do what you will with. And then you can think about the extraintestinal manifestations as well. So patients who may have Crohn's disease are more likely to have some extraintestinal manifestations. Again, some won't. But you think about the classic extraintestinal manifestations like mouth ulcers, pyoderma gangrenosum, erythema nodosum. Those are rare, but they occur probably in up to, there's some studies that say up to 5% of patients with Crohn's disease. I think in practice that seems a little bit high. And then you have, perianal fistulizing or abscesses, and you have joint symptoms in patients with inflammatory bowel disease that sometimes mirror the bowel symptoms, and that can be a clue. And then, so iritis, uveitis, episcleritis. So those can all be clues, but you can, again, get patients with many of these things without a history of inflammatory bowel disease. And so then you go through, okay, are there red flag features that they need an endoscopic assessment? On endoscopy, I typically will do just a colonoscopy if I'm suspicious. If I'm suspicious that they have more obstructive symptoms, more bloating, if they're having weight loss and poor nutrition, I'd be more inclined to also investigate the small bowel. But with a colonoscopy, you can assess the entirety of the colon. You can get into the distal ileum. And if I have suspicion, I do make sure that I've gotten as far into the ileum as I can. And that's going to obviously depend on a lot of factors, making the colonoscopy easier or harder. But making sure that I have at least seen the distal ileum, I think, is important. And then that's where your endoscopic and biopsy assessment comes in, or histologic assessment comes in. So are there ulcers throughout the colon? Are there ulcers in the ileum? What is the distribution of it? And on histology, is there any signs of chronicity to inflammation? Because there is often patients who you take biopsies of some subtle change and there may be some acute inflammation, but no chronicity. So in those cases, if everything else doesn't fit, I wouldn't put a label of inflammatory bowel disease on that. There's some things that kind of cause suspicion, but are a bit of lack of clarity with the diagnosis. So if somebody's also taking NSAIDs and then you go in and they have ileal ulcers or apthi, that's not going to be a specific diagnosis. It could just be from the NSAIDs, but that you try to kind of get them off the NSAIDs and then see how they do over time. All of that to say, there's not a lot of really specific one clear answer. In patients who have just small bowel disease, if it's not an area that's accessible by endoscopy, which it can be, you can have kind of mid-small bowel disease. If there's really clear radiographic findings without a lot of suspicion for other things, then I am comfortable making the diagnosis of Crohn's disease based on that. But that one would have to be a really clear radiology report. It would have to be a radiologist that I am able to communicate with and kind of clarify the questions I have about it. And it has to be something that doesn't have a lot of diagnostic uncertainty to it. So if there's a lot of other things on the differential, if there's a question of, could this be a malignancy, then I need tissue before saying no, right? If there is a history of tuberculosis, then that adds to that lack of certainty. But there are some of those patients that come in who have patchy inflammation through their small bowel with strictures, with pseudosacculation, with mesenteric fat stranding around the inflamed areas. And it's just not in an area that's accessible by endoscopy. And those are patients that I'm comfortable making a radiographic diagnosis of Crohn's disease. There's always going to be that little bit of uncertainty in those cases, but I think that it's clear enough, as anything in medicine is.
I think what I take away from all that is that you really have to put all the features together. I also appreciate the fact that I think as surgeons, we see end results of significant disease. And so for us, I often feel like when we see imaging features of Crohn's disease, it's usually because they're having a problem, like they're obstructed or they have fistulas or an abscess. And so it's probably less uncertain or unclear to us. But certainly, like, I think I appreciate the complexity and the nuances of making a diagnosis like this. So I think that it's important that we're all aware of how nuanced this decision can be. I find that folks who are really who really deal with a lot of IBD spend a lot of time talking about the sort of the pattern in which they present. And so, you'll often see folks like yourselves in their reports talk about, is this a fibrostenotic or is this a stricturing disease, or what the pattern disease is? Can you talk to us a little bit about why that makes it different and what those overall sort of patterns are?
I'm not sure when this classification came about, but I think it initially came about for research purposes, and then it's had a pretty good application clinically. But we use the Montreal classification for Crohn's disease, which is it has the age at diagnosis, the disease location, the disease behavior, and then there's a modifier for perianal disease. So the age at diagnosis is under 17 years, 17 to 40, or greater than 40. And then the disease location, you would classify that as ileal, colonic, or upper GI. And then disease behavior, and we talk about it as non-stricturing, non-penetrating, which usually from my notes, I'll just label that as inflammatory because it's fewer letters. And then you have stricturing, and then you have penetrating. And then historically, I think when this was first developed, the perianal disease, it doesn't really fit with penetrating disease. It doesn't really fit with, an enteroenteric fistula or an enterovaginal fistula, because it is a different behavior. And so the perianal disease, like fistulizing disease, was added as a modifier then, rather than as kind of in keeping with the fistulizing or penetrating phenotype. And when I think about then those kind of phenotypes, so the inflammatory phenotype, different literature will say different numbers, but between 50 and 80% of patients with Crohn's present with an inflammatory phenotype at diagnosis. So that's the inflammation on scope, on imaging. It hasn't caused strictures or fibrostenotic disease at diagnosis. You can see a wide variety in that presentation. So that includes the patient who has, 10 aphthous ulcers in the distal ileum, but it also includes the patient with deep serpiginous ulcers in the ileum and the rectum. That's starting to get maybe a little bit narrow looking on endoscopy, but you don't have definitive stricturing disease. So that's a very broad spectrum of patients. In the inflammatory phenotype, I think it's important to kind of characterize that because it is the most likely to respond to medical management. And that's really the patients that, if we could diagnose every patient when they have an inflammatory phenotype, I think that we would have much better outcomes over time, right? But about 20 to 25% of patients don't present with an inflammatory phenotype. They present after strictures have developed. And so that's where I think the clarifying the phenotype is really important, because once we have strictures developing and once we have that fibrostenotic process that's developed, we don't have a really good way of aborting that process. And there's even some studies that show that if you have a patient who's started to get fibrosis, so just the start of stricturing, and you get them on a biologic and you get the inflammation calmed down and healed, that fibrotic process still develops. There's a lot of ongoing research into this. There's a couple of consortiums, as there is for everything, looking at kind of fibrosis in IBD specifically, and that there is some evidence for some of the biologics aborting that process, but then there's some evidence that it's really hard to do. And so if we can catch more patients at that inflammatory stage and we can treat it at the inflammatory stage, that's when we know we have a lot better luck getting kind of avoiding those negative outcomes. And I say negative outcomes, but fistulas and abscesses, they are negative. So that's kind of inflammatory. we do know that with the inflammatory or the non-stricturing, non-penetrating phenotype, about 20 to 30% of patients who present with non-stricturing, non-penetrating, that will stay their disease for their disease course. They will not develop stricturing. They won't develop perforations, abscesses. We just don't know necessarily who that is. We have some ways to kind of estimate that, and we can talk through that kind of when we think about severity as well, but it's hard. I tell my patients a lot that I don't have a crystal ball, and one day we might. It'll probably be blood work, not an actual crystal ball, but it's hard to predict who those people are. I talked a little bit already then about the stricturing phenotype or the more stenotic disease course. And again, up to 25% of patients present with strictures at their diagnosis. Some studies say a little bit higher, some studies say lower. I think it just depends on your population. But when you have strictures, again, you're less likely to be responsive to medical therapy. If you can get the inflammation under control, and then you're left with more of a fibrostenotic stricture, those are patients that surgery actually may be a very good option for, especially if they're developing obstructive symptoms. If they're not having obstructive symptoms and they're managing and they have a slight fibrostenotic stricture, those are patients that I, advocate for watchful waiting in and just monitoring. And then there's also the potential for endoscopic dilation in stricturing disease, because at that point in time, I think of it more as a mechanical issue. And it becomes a little bit more straightforward to me, but it's actually sorting out, is it inflammatory? Is there inflammation there? I do use fecal calprotectin to help with that. And I do really rely on imaging and the radiologist's description, as well as the endoscopic assessment if it's reachable. The European Crohn's and Colitis Organization in 2018, they did a guideline for kind of the use of surgery in inflammatory bowel, or in Crohn's disease specifically. And that kind of echoes that idea that fibrostenotic strictures with obstructive symptoms, especially in an ileal location, surgery is a really, really good option in those cases, and really one of the better options, because the endoscopic dilations over time, usually they end up with surgery anyway.
Yeah, totally.
Not everybody does. And then the penetrating phenotype is the one that kind of worries me the most, in part because I'm the least confident that that is going to respond to medical therapy. And I think that there's a couple of factors with that. One is that when you have a penetrating phenotype, when you have abscesses, fistulas, you often have infection, and you often have, I can't start an immune suppressant when you have an active abscess. And that's not a kind of hard and fast, you can never have TNF or another biologic. And our medications are actually not all that immune suppressing. But if you have an active infection, they're just not a good option. And so then we're fighting this battle of get the infection treated, and then maybe we can start, but we don't want another abscess to form. And it's this hard fight. These patients also tend to have really increased nutritional requirements. And so that's something that I think we often miss, because that's going to lead to increased infection risk as well. And I think you and I have shared a couple of patients that this has been quite a challenge with, because I think by the time they present with penetrating disease, that didn't start yesterday. That didn't develop suddenly. There's some people who have really, really aggressive disease and it did develop quickly, but that's not the norm. Usually those are the patients who are very minimally symptomatic when they're inflamed. And then they're very symptomatic when they have an abscess or a stricture. And so those are the ones that the disease has been pretty progressive to get to that point. And so I'm less confident that my medical intervention is going to have benefit. And that doesn't mean that it never will, but I'm less confident in it.
Totally. I think this is where, some of the really challenging patients that we have to deal with in the hospital, trying to make a decision about what would be the optimal therapy for them. I think this is where it's essential that you have really good relationships between general surgery, colorectal surgery, and your inflammatory bowel disease colleagues, because these are not straightforward decisions. And I found the most benefit, or the most like the best sort of way to deal with these things, is just to sit down and have a discussion. And I think you and I have both trained in Vancouver, where we had fairly robust GI colorectal rounds, and we've started to do that here at Queen's as well too. I found that incredibly helpful to be able to sit down, look together at all the imaging and discuss these cases, because I find that often there's nuances from both sides that come out only in the discussion. So yeah, anyone who's listening to this, I think it's critical if you're dealing with any decent amount of IBD, that you have some sort of systematic way of talking with your colleagues about this.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.